what I want to do, I want to go through a few minutes talking about some of the statistics around CAMS. I'm not actually a CAMS clinician, I'm an adult psychiatrist, but I do a lot of work with our CAMS service because I'm also the digital mental health lead for Lothian, and we've done a lot of digitization within mental health to enable them to carry on seeing young people by video calls when they can't come into the clinic room and that sort of thing. And CAMS in Lothian have really embraced that. It's not as good as face-to-face, but it's a lot better than phone. So I do know a reasonable amount about the CAMS service in Lothian, and I'm going to show you just some stats around a range of things across the whole world. Some of these are some Australian stats. When I was living in Auckland, I spoke to a similar group to this in Melbourne, and the story is the same the world over. And then I want to move on to talk about, well, actually, how do we do this? Because I'm assuming that most of you are not CAMS mental health professionals. You've probably got more generic roles. So what is your role in that? And I'm going to try and go through stuff fairly quickly. We can get these slides shared around later, and the talk's being recorded anyway, so you can come back to it, but I want some time for discussion at the end. We've spoken about the Mind and Soul Foundation already, but there's the web address and it's down the bottom of all of my slides. Sorry, not quite sure why that's jumping forward. The good news is that we've actually set up a specific resource called Headstrong. The website is there, beheadstrong.uk, and it's a partnership between Mind and Soul and one of the major youth charities called Youthscape, and one of our directors, Dr. Kate Middleton, is on it, not the Duchess of Cambridge, the other famous one. And being headstrong is all about how to have positive mental health. I think sometimes it seems that everyone's got a diagnosis or a problem or something like that, and headstrong is the opposite of that. What does it mean to thrive with your emotions as a young person? And it's aimed at youth workers, young people, pastoral workers, like I know some of you are who work with young people. So beheadstrong.uk, there's all sorts of resources there, snippets. It's quite trendy. If some of us older people look at it, we'll notice it's one of those sort of skinny websites, and that's because it's designed to be read on a phone. You actually do far better looking at it on a smartphone, like most of the young people will do. But these are some Australian numbers. So if you multiply, well, you can do it this way. So it's about 15 million people in Australia. So if you divide this roughly by 3, that's what is the situation in Scotland. But I put some Australian data up just to say it's the same. You know, we've got people dying from suicide every day. We've got fairly high prevalences. I mean, whether it's 1 in 4 or 1 in 3 or 1 in 8, I don't think we can argue about those things, but those figures are pretty high. Depression and anxiety. I think anxiety is the sort of silent thing, I think, because a lot of us push on through with anxiety because we kind of have to get out there, have to get out and about, but we're not really, it's not like, if you've got a fear of heights, you can benefit from doing some graded exposure and perhaps learning how to abseil and overcoming it, and you're never going to like heights, but you can overcome a fear of heights, whereas a lot of the anxiety is much more embedded, perhaps social anxiety, fears, worries, and actually the simple exposure doesn't work for that. So we need better help for those people. And likewise, depression, again, whether it's severe depression, we might say is 3%, depression of some kind, 10% at any one time, some sort of episode of depression at some point in our lives, perhaps a quarter of people, you know, so it depends where you put the severity cutoff as to what those numbers are. The things that we always get worried about are, of course, suicide rates, and that's what hits the headlines. And I just wanted to put a few graphs up there. I think we just need to remember that it's not a complete disaster. Okay, so on the left here, you've got suicide rates per 100,000 people across a number of quite different countries. And generally speaking, the trend is down. Now, there's a bit of an up towards the end of this graph, as it turns out. But, you know, since the 1980s, we have got actually better with this. You know, less people are dying from suicide, and we need to hold on to that, and we need to remember that. And this graph on the right is some data from the World Health Organizations looking at all parts of the world. And again, a downward trend in suicide. Now, we've got a long way to go. It's still the biggest killer of certainly men of working age. After road traffic accidents, it is the next biggest killer. It is the biggest killer of women in the postnatal period. You know, more infection we've dealt with. It's suicide in that group that is where we need to be going next. So these are still serious problems, but there have been improvements, and we can't be sort of reading too much into the newspaper headlines. But there are some particular focuses to look at. So this is age groups along the bottom. So we're sort of down the bottom of the graph here, looking at children and young people. And what you can see is that Scotland has this excess peak, and also Northern Ireland has this excess peak, particularly in young people. And that's what we're seeing now, is we know that Scotland has a higher suicide rate than other parts of the UK. And we also know that if we look at that in terms of gender, it's worse in males than females. There are higher rates here and men among females, and there's a number of reasons for that. One of that is that females tend perhaps to take overdoses, which can often be treated, whereas men will take their life by something rather more damaging, such as hanging or something like that. So we're still seeing, we know we need to be targeting young men, even though overall the suicide rates are dropping. Now, what we're seeing here is that acute presentations are on the up. This is hospitalizations per 100,000 people. And what you can see here is, you can see particularly young women are getting more bed days than they ought to. There's obviously a certain level of distress in the population, but this group here, young women coming into hospital, and you might have heard about people being admitted, sometimes under the Mental Health Act, just often for quite short periods, because someone presents to A&E or something like that, and they're suicidal, they're estranged from their parents, and no one's quite sure what to do. And these are people who often haven't got great supports and coping mechanisms. For people in these sort of age groups who are presenting, they often do have friends, family, they've had a period of good mental health, and they have got those networks and supports before they began to struggle. But a lot of young women in particular seem to be presenting and being admitted. And the problem is that hospital's not the right place. It might be the right place very, very short term to protect people, but it's almost certainly not the place where people are going to be able to stay for the length of time needed to get better. There just are not the resources there. And it's also not necessarily a helpful environment. So hospital rarely actually is the answer. This is just some wider data, not just about young people, but what you can see is that the blue line, as the number of psychiatric beds has gone down, the number of people, the red line, detained under the Mental Health Act has gone up. And certainly if you want a mental health bed in London, it's pretty much impossible to get one unless you're detained under the Mental Health Act, because that is the level of the bed provision. Now, some of these beds have been closed for good reasons. You know, if you go back before 2008, if you go back to the first half of last century, we had the closing of the big asylums, and there were big cuts in bed numbers. And care in the community, while not being fully rosy, I think saw a lot more independence for a lot of people. But we're now at the point where the bed numbers are getting relatively critical. Unfortunately, it's often finances that are driving that. And what we're seeing is an increase in detentions, more ill people in hospital, more self-harm and suicides among patients. So this is not people out and about, this is people on wards. And it comes back to what I was saying before, that, you know, we think, well, this person just needs to be admitted and they can only get better. No, these units are not necessarily as safe as we would like. And that's nobody's fault. It's often slightly can be a pressure cooker going on, and you know, admission is not always the answer. So we just need to remember that if people are not admitted, it's not always because, you know, we don't think it'll help. There's often good reasons around that. We don't think it's the right thing. Now, the money's been going up. This is another Australian slide, so you can divide this by 3 or you can multiply by 4 for the whole of the UK. But as you can see, this is the Australian slice budget going up, and you've seen extra bits and extra bits and extra bits being put in. And actually, we've seen similar increases in money. I could show you a very similar looking slide, which is the number of CAMHS professionals, not just the head count, but also the number of whole-time equivalents going into CAMHS services across Scotland. So we've seen more people. Lothian, I think, was given, I think, an extra 1.5 million to spend on CAMHS services. So we have seen CAMHS services increasing and expanding, but it's not necessarily the answer, because what you can see here, the graph on the right, this is the percentage people starting treatment within 18 weeks. So you can see back in 2015, we had 80% odd of people who were starting treatment. This means that they've been referred, they've had an assessment, and they're actually starting treatment. That's what completing the journey means. But as you can see, that percentage has declined over recent years, and there's a couple of health boards that are doing particularly badly, and Lothian is doing quite badly in this area. It's probably one of the worst areas in Scotland, but not necessarily the fault of the professionals, because what's happened is the referral rate has almost doubled. So if you are getting double the number of referrals, even if you've got another 10% more staff, you're going to be seeing less people. You're going to have longer treatment delays. What do we do about that? So there's been some government initiatives. You can look at these links later. There's a national framework for CAMS. If you go to the website for ISD, which is now called Public Health Scotland, you can get all the charts and the statistics if you like that sort of thing, and that's where this graph came from. You can look at the health board pages. This is the CAMS page. It's much the same as the Forth Valley page. You know, all these things are relatively similar, and there's quite a lot being spoken about with rejected referrals at the moment. You know, if the GP refers someone to CAMS, often it seems to have taken quite a lot of work to get there. And then if a percentage of those referrals are rejected by the health board, that can be a real blow. But if you think about it from the other end, if you have a finite capacity, either people wait 6 years for treatment, by which time, of course, they're not young people anymore, they're adults. And you know, a 6-year wait is essentially a waste of time, or you have to reject a percentage. So we're still flashing that out one. It's quite a political hot potato. And what is increasing? We are seeing increasing money for the health boards, but we're also seeing an increasing amount of other tiers of help. So CBT, computerized CBT, being offered as something which is much more scalable. There's only a certain number of psychologists out there, and they take years to train. So we can't just grow them on trees. So computerized CBT is an option. DBI, distress and brief interventions, is a daily support distress reducing phone call for several days or 2 weeks after an acute presentation. A lot of these things are now being rolled out down to the age of 16 or even lower in some areas. NHS 24, which is our national, when you dial 111, that's who you speak to. They've got increasing resources, and of course non-NHS. So you've got, yes, you know, your GP's referred you to CAMS, but actually, what if the problem is a social problem? What if it's a financial problem? What if it is a relationship problem? What if it's a academic problem? You know, CAMS is not necessarily the panacea and end point for all referrals. So there's a lot going on at the moment, just to put it in context. But I think what we can see is that it's the current model, i.e. you've got a sick person, you refer them to the GP, they go to CAMS. That's not working. This is an ambulance by Beachy Head. And for those of you who know the south coast of England, Beachy Head is a place people go and jump off to end their lives. And the ambulance, first of all, the ambulance is at the top of the wrong hill. That's Beachy Head behind. And also you don't put an ambulance top of Beachy Head to catch people. You need to think differently. We're pouring money into the system, and I'd say at some level it's the wrong model, and also perhaps more importantly, it's missing a trick. And this is where you guys all come in, because you're doing really, really important work. I wanted to spend a few minutes talking about the more severe situations, just to sort of say we know what's going on, if that makes sense. But I don't want you to get overly focused on the couple of cases that you know about where people are really struggling, because that will stop you doing really, really, really important work with everyone who's involved in your care, which actually is as effective. So let me explain what I mean. We can work with everybody in schools, and there are some who we will work with in guidance departments and things like that, and only a very small minority will need a referral. And if we focus on them, we miss the opportunity to do the pastoral support and to work with everybody. So that's something you might want to sort of pick apart in your small groups, is where is your focus at the moment? And I want to talk a bit about prevention, which is, you know, closing the stable door before the horse has bolted, if that makes sense. By the time someone gets to needing to see a psychologist in CAMS, they're often out of school, etc., or not really learning anyway. But there's so much we can do earlier than that. And there's lots of excellent research about it. These are opportunities to do prevention throughout life. So, you know, for older people on the right here, we've got social connection. For adults in working age type situations, you know, community, working life, relationships, loss of employment due to mental health problems costs us, this is a Lancet Psychiatry article, £23 billion a year. The cost of mental health disorders in the UK is significantly in advance of the cost of cancer or heart disease because it affects people early. But here, perinatal mental health, dealing with the child almost before they're born, if that makes sense. Preschool work with parenting in school before further education. And we know that 75% of mental health problems are set, you know, stuck, if that makes sense, by age 24. So can we intervene early? And that Lancet paper, I've put that in there because it is an academic paper, but the PDF is freely available and it's surprisingly readable because what it does is it takes you through the evidence around mental health prevention. And there are all these different things that you can intervene in. Now, don't worry about these complicated sounding genetic things. We're not asking you to do genetic engineering, don't worry. I don't think anyone's going to be doing that for several decades yet. But there are some biological things we're understanding more, and there's what can we do with the families. We know that maternal depression is a big factor. You know, social work are very involved around neglect, but what can we do to intervene here? Bullying, stimulation, social adversity, economic disadvantage. These are areas where actually we can intervene. And some of the evidence there is actually in this blue part of the graph. Yes, you know, tertiary, CAMS, they will treat established illness. That's what tertiary prevention means. The person has become ill and we're now treating them. Secondary prevention, where the person is becoming ill. And can we intervene early there? Early detection, improved access, you know, a long wait for CAMS, almost no point in that. We want the early support coming in there. But there's so much that we can do here. School-based programs to foster healthy eating or positive coping skills. I'll be honest with you, it can sound a bit naff, okay, that we're going to have a healthy eating day at school. And I know it sounds a bit naff. And I know some of the parents say, oh, what are you doing another healthy eating day? Or why are you sending home the resilience jam jar and all that kind of stuff? But what we know is that this stuff actually does work to prevent mental health problems. And we've got to be getting in there with prevention. What works? Mental health promotion, you know, just talking about it. Universal, what works for all primary preventions? You know, school-based programs to prevent bullying, targeted primary preventions, working with people in whom you know that there's a family mental illness, for example, but the child himself is currently doing okay. How can you support, encourage, mentor, if that's the right word, buddy, whatever, you know, that young person to help them cope with the adversity of having a parent who might be ill? And, you know, what can you do? People who are at high risk of psychosis or, you know, perhaps beginning to struggle to some degree, how can you get a bit of extra help for them? They're not ill, they're just struggling. So things that we can do there. The problem is we're not very good at doing prevention. We tend to focus on the high risk cases. And there's one of the problems with that is that people don't like to come forward asking for help. Those at statistically the highest risk don't tend to ask for problems. They often just want to put that lot to one side and just kind of get on with it. We're not very good at measuring prevention. It's easy to measure CAMS referrals, but how do you measure prevention? How do we show that we're making a difference there? It's hard to do ethical research on this. You can't exactly randomize people to have prevention or not. So there's lots of false positives in the research. It's quite long-term stuff. You know, if you intervene with prevention now, you're going to see the benefits in 10 years time, 20 years time. And that's not very attractive to funders or in particular politicians who are interested in being re-elected. There's no money for prevention. You know, what do? Do we cut CAMS services in half and say, right, we're going to halve CAMS services and put all this money into mental health promotion? We think the maths would work, but it's actually quite hard to prove because no one's ever really done a study that if you intervene in 100 people, you're going to get half the cases less in the future. So that research is tentative at best. And you know, we're fairly sure from the work that's been done that if we intervene, we do get less, but that's sort of scaling up to the population level is quite scary. Could we cut CAMS services in half and do mental health prevention? Potentially, yes, but that will be a very big risk to take. and the stigma. Needing help is weak. You know, you can see cardiac risk, you can see the risk of obesity, you can't necessarily see the risks of mental health problems. Now, resilience, I'm not going to talk about. I'm going to touch briefly on two controversies because people put in some questions about these. And then I'm going to let you get off to your group before I take up all the time. The first is about mindfulness. Now, the reason why we talk about resilience is one of the ways to be resilient is to be mindful. Mindful very simply just means to hold things in mind, you know, so you were just thinking about the issue rather than suppressing it or avoiding it or reacting to it or something like that. You know, you're not becoming angry or aggressive, you're not becoming depressive and internalizing, you are simply becoming upset, simply becoming mindful of it, and you have the skills around that. And mindfulness is one of the things that people are often asked to teach, and people say, oh, isn't that a Buddhist thing? There's a great quote from John Kabat-Zinn, who is the founder of the clinical applications of mindfulness. He himself is a Buddhist, but he says mindfulness is no more Buddhist than only the English will respond to gravity because Isaac Newton discovered it. You know, we don't think, oh, Isaac Newton, he was English, therefore I'm Scottish, gravity doesn't apply to me. Ridiculous concept, isn't it? And in actual fact, mindfulness is there in all the world's great traditions. It's there in Celtic Christianity. It's there in Catholic pilgrimages. It's there in Sufism, in Islam. It's there in all of the world's great traditions. So yes, it can be a Buddhist thing, but it can also be a Christian thing. And there's a website I put up there, christianmindfulness.co.uk, run by a friend of mine, Richard, who lives up in Dundee. And there's all sorts of resources there about mindfulness from a Christian point of view. There is, however, a note of caution, the idea that everyone can just run off and start running mindfulness classes for mental health conditions. You can do some mindfulness and you can do some stretching in the park, but you wouldn't call stretching in the park yoga. And we shouldn't call mindfulness for mental health conditions. We shouldn't just run off and do it because, I don't know, think an example. You've got 10 people in the room, you're all trying to be mindful, and one of the persons says that they're feeling suicidal and they're not feeling very safe. And what usually happens is an inexperienced coach will respond to that in a completely non-mindful way, completely overreact, have to report it to their line manager, blah, 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 blah. And the whole concept of mindfulness around mental distress is completely nullified. So what I would say is you need to be trained to deliver mindfulness specifically for mental health conditions. If you want to do mindfulness for other things, that's fine, but don't go diving into mindfulness for mental health conditions. The other thing about sharing faith, and the reason I mentioned resilience and prevention and that sort of thing, we need to remember that when you look at the resilience research, the single biggest protective factor that makes people resilient is faith. If you look at all the research across the world, faith makes people resilient. Not just the Christian faith, but often, because that's often where the studies were done. But we know that, you know, it's as strong a factor as having a stable upbringing. Okay, it's as strong as that. And a stable upbringing, we can't wind the clock back. So actually bringing faith into it is a way to compensate for some of those other resilience factors that are not present and are never going to be present. So I think, as Andy was saying earlier, you know, that the imperative there to engage with matters of faith, the reason for that is that we know that evidence is around this as a key factor for resilience and prevention. So we shouldn't be afraid that we're doing something under the carpet. And also Christianity gives us that model of ups and downs. Jesus experienced a full range of emotions. So we need to make sure that our churches and our faith is allowed to embrace the full range of emotions. Some churches always seem to be down the dour end of the spectrum, and perhaps a bit more happiness would be good. Some churches always seem to be happy and clappy and all that kind of thing, and perhaps a bit more lamenting would be good. So I think the model of Christian faith that we put forward affects how effective it's going to be for our mental health. So I'm going to put you into some groups. You've got 15 minutes and then we've got time to get back for questions. And what I'd like you to think about is give some examples of mental health promotion. And I'm just going to go back to this graph here. What have you seen here? Have you seen things that are promotion for everybody or targeting all people in school? What are the other examples that you might think, or things that are targeted primary? So universal primary, targeted primary, indicated primary, you know, targeting people who are perhaps at risk of becoming ill but are not ill yet. What prevention are you currently doing in your school? You'll be doing something. You know, it might be a resilience jam jar, it might be something else, but I think you will be doing something. So talk about that. If you think the resilience jam jar is a bit naff, share that in the group. It's all right to get it off your chest, that's fine. How easy is doing all of this alongside teaching? And what I mean by that is you've all got full-time jobs, haven't you? And I know some of you are teachers, some of you perhaps are specifically here to do this kind of thing, to support the teacher, because you know the teacher is busy teaching. How does that balance work out? Have people got time to do this? And also, how are you doing yourself? You know, I think we've all been under stress with coronavirus, and if everyone's stressed and no one's looking after anyone, then that is a recipe for disaster. And a healthy you is the best way for you to help other people. So how are you doing yourself? And are there perhaps things you need to do yourself? I'm going to stop sharing at that point and hand back to you, Andy.